It's our privilege and pleasure to be with you today. My name's Richard Penson, and this is
Laura Sullivan.
She's our practice nurse at MGH. We're going to go through some didactics in half an hour, 40 minutes, and then we have 6 classic cases, our own patients, to illustrate the things we've learned. So the outline is to do a primer in ovarian cancer, and then talk about the 2 most recent drugs, olaparib and bevacizumab, to be approved for ovarian cancer, and then talk about the interest in immunotherapy and how we're thinking about that right now. There's no approved agent. And then, as we said, anchor the discussion in clinical cases. So a primer. This is a classic paper from 16 years ago. Bob Weinberg in Boston came up with these 6 major drivers of cancer. And then a decade later in review, added other key components. And so genomic instability has been one of the most interesting things. And we're going to put, I think, a reasonable emphasis on this with respect to DNA repair and the development of the PARP inhibitors. The microenvironment and the immune system, though, is really interesting, and that's sort of the next frontier. At that sort of time, this was a review from 2009 about the genetic aberrations in ovarian cancer. And sort of humblingly, a year later, we discovered a new gene, a tumor suppressor gene that's lost in endometriosis and allows cancer to develop. And we sort of were learning that the incidence of these oncogenic drive mutations was much rarer than in other diseases. So PI3 kinase, not 8%, but 4%, so probably even less than that in high-grade serous tumors. And it became clear that amplification of genetic material was really what drove a lot of the biological behavior of ovarian cancer. And only, after this same review paper, 2011, chromothripsis, the shattering of chromosomes, is thought to be what really drove that. So this is a slide. If any of you are really astute, somebody gave me the slide. Very famous people gave me the slide, and you can sort of tell this is not a woman. But it shows how we do interesting things with our slides. And there's a huge number of chromosomal aberrations. So this black line here represents the normal paired chromosomes, which are obviously lost, or there's huge amount of genetic gain, and this is an ovarian cancer patient. So it's this genetic catastrophe illustrated here that is so significant. So if you look in this first panel of the 23 pairs of chromosomes, look here, instead of 2 chromosomes, there are 6 chromosomes in this ovarian cancer tumor. So you can see in multiple places there are dramatic, what's called aneuploidy. DNA repair is a key driver to what has failed and what causes that sort of situation. So we have 3 billion bits of code in each of our cells. So if you were to extract DNA from a human cell, it would be 2 meters in length. It's folded in incredible fashion. So in a single person, that's the length of DNA. That would get us to and back from Saturn 134 times. And you sort of say, no, you are joking. And that is just impossible to get your mind around that. So in an average human being, there are 10 to 30,000 episodes of DNA damage in a day. And we're not going to go through this, but repairing DNA damage is a key to human integrity through their lifespan. And that's what starts to fail as we age and as cancer develops. So this was our old understanding. There's here an ovulation, and after ovulation, a cyst is left behind. Within that cyst, metaplasia happens. That becomes pre-malignant, becomes a cancer, and that invades and metastasizes. This was the old theory about ovarian cancer. And 3/4 of the tumors have these classic slit-like spaces. They are serous tumors. We started to understand the genetics of that, loss of the guardian of the genome, P53. But then it became clear that actually about half of the tumors start on the fimbria, the fingers of the fallopian tube, with this stick, serous tubal in situ carcinoma. And now we really do divide this up into 2 types, type 1 and type 2, endometrioid clear cell mucinous tumors. And endometriosis is probably the precursor to quite a few endometrioid and clear cell tumors. And we're starting to understand the genetics of those and other things like low-grade serous tumors. The best drug is unequivocally platinum. So this describes in summary platinum pharmacology. The old drug cisplatin and the much more commonly used drug carboplatin bind to a fairly specific place in DNA. So if I illustrate that in the cartoon, you have within DNA strand intralink and interlink adducts. And it is the removal of those, mainly by homologous recombination, that's really important. And so this is the key link into BRCA mutations and why patients who have impaired homologous recombination, you can see BRCA1 and 2 are key members of this DNA repair. That is an opportunity for different treatments. When I was a medical student, this was the old way of thinking about things. ATM was the sensor, P53 the policeman, and P21 the executor. And either P53 decided that you were going to suicide that cell, or you were going to halt the cell cycle and repair DNA. Our understanding of that now is much more complicated, and we're not going to go into this sort of detail. But if I blow up that area that we were looking at before in terms of DNA repair, PARP inhibitors, which is really what it's exploiting that, when you have a BRCA mutation and there's some impairment of homologous recombination, are key to the development of other repair mechanisms. The PARP inhibitors prevent that green chain, the polymer of ADP, ADP ribose polymer, that is the structure that holds the enzymes in place to do DNA repair. So if you give a PARP inhibitor to interrupt the development of that polymer, you hit two ways in which DNA is repaired and you kill cancer cells. That is called synthetic lethality. So in this panel, you have the sort of overall diagram. So the other repair mechanisms, we'll talk about more of that in a moment, that are affected by PARP inhibitors, and homologous recombination, which has as a key player BRCA1 and 2, are involved in repair. In cells with BRCA mutations, this is impaired, but you have intact repair through the other mechanisms. If you give a PARP inhibitor, you still have this mechanism. So it's only in the situation where you have synthetic lethality, because you've inherited, or now we understand acquired, a BRCA mutation, that when you give a PARP inhibitor, you can trigger cell death and a response in tumors. The old theory was that it was basic excision repair. A newer theory was that it was non-homologous end joining that was most different, and these were different enzymes. Again, PAR, important for this. The latest situation is that it is basic excision repair, it is non-homologous end joining, but there are other mechanisms. What's called PARP trapping. PARP1 is probably the most important enzyme. And there's other end joinings and polymerase epsilon and other ones. So our understanding of this is a little bit in flux, but the principle is now clearly established. Ovarian cancer is illustrated in this TCGA, the Cancer Genome Atlas, with purple. So ovarian cancer in purple was looking at all of the genetic aberrations. And you can see in the ovarian panel, there's not that many oncogenes. It really is a tumor suppressor gene dysfunctional disease that allows all that aneuploidy to happen. It's notably different. So the Cancer Genome Atlas, when it came out, and you should know that this is really only high-grade serous tumors. They did not look at endometrioid or clear cells or other. This panel here, 33% had BRCA1 or 2 mutations that were inherited or acquired. And we'll talk more about this pathway a little bit later on. If you go to the Cancer Genome Atlas website, you're actually adding up all these different ways that homologous recombination can be disrupted. 51% of patients have that in high-grade serous tumors. So this is a very famous figure. Some of you may have already seen this figure, and it looks like nearly 3/4 of patients have some aberration of DNA repair. This is our own A.K. Goodman. This was a student. It shows you how dangerous it is writing review articles. I have seen so many people copy this figure, which is a little bit of an exaggeration. I don't know if you know anybody else, but I'm prone to exaggeration as well. This is the best data. This is Panos Konstantinopoulos' very nice review from last year. And so these figures are absolutely right. About 8% of patients carry a germline BRCA mutation, slightly fewer BRCA2 mutations, and then these are the acquired mutations that happen slightly less commonly. This is really now robust figures that seem to be pretty stable. But nearly half do not have homologous recombination deficiency, and it's this other group where we think PARP inhibitors may work that's garnering a lot of interest at the moment. So let's take our patient. Our patient presents with pain, nausea, bloating, urinary frequency, that sort of thing, and we do an evaluation. And the real backbone to clinical evaluation is the exam, but also the tumor marker CA125. It was the 125th attempt to find a marker. It's a glycoprotein on the surface of tumor cells. And there is clearly the need for a CT scan. And using that, some patients are never going to get surgery. Many patients, now 55% at our institution, start with chemotherapy and get an interval cytoreductive surgery. And often we'll do a laparoscopy to evaluate the need for laparoscopy. So Meigs was the founder of surgery, and really our sort of culture has changed. Meigs was a surgeon at MGH approaching 100 years ago. And we evaluate who's a good candidate for immediate surgery, what you might call primary cytoreductive surgery, looking at the perioperative risk, which is mainly driven by age and comorbidities, and then the likelihood, and most people look at CT scan, and CA125 has really fallen out of favor, of getting an optimal, leaving behind less than 1 centimeter, or a complete resection to zero, what's often called an R0 cytoreduction. So there's sort of two ways of thinking about it. We either do interval cytoreductive surgery or primary cytoreductive surgery, and patients start with neoadjuvant chemotherapy, get half of it, and then their adjuvant chemotherapy after the surgery, or adjuvant chemotherapy. And I'm not going to review the data, but these are essentially equivalent. Everybody gets platinum-based combination chemotherapy, and there is data to support any of these combinations. There was GOG 182, which showed that all of these were pretty much equivalent up front, as long as you got some Taxol. And there's other data, randomized data, that says you can get Taxol later and do paclitaxel later and do just as well. The big question that many people have is, are they going to give weekly paclitaxel to exploit a schedule advantage for the taxanes, or bevacizumab? 40% of US patients get bevacizumab. And if you give weekly paclitaxel, it really sort of counteracts or it exploits the anti-angiogenic benefit of bevacizumab. So you should not be doing both of those, but you can do carboplatin and dose-dense paclitaxel and get equal outcomes to if you added bevacizumab in terms of progression-free survival. Intraperitoneal chemotherapy has got much more complicated since GOG 252 was reported, and so these are all options. An outpatient treatment with 75 milligrams per meter squared of cisplatin and 135 milligrams per meter squared of paclitaxel, typically the next day over 3 hours. Some people will put it on the same day. There's a excess of neurotoxicity with that. And then a week later, getting IP paclitaxel 60 milligrams per meter squared. The traditional way to do it is to give both on the same day, day one, with 100 milligrams per meter squared of paclitaxel, but otherwise the same day 8 dose. And since the Canadian data, weekly paclitaxel over an hour, 80 milligrams per meter squared given IP is potentially an option for treatment as well. We always encourage people to enroll in clinical trials. Recurrence is all too common. 80+% of patients are going to have recurrence of disease, and the commonest way that we see that is with a rising CA125. So if the recurrence is within 6 months, we call that platinum-resistant disease, and if it's later than 6 months, we arbitrarily call that potentially platinum-sensitive disease. So if a patient presents a few months later with a rising CA125, we have to carefully consider what's best. If they're asymptomatic and we start treatment, we adversely affect their quality of life. And if we leave disease till they have multifocal, bulky disease, we compromise their survival. All of the treatment is palliative. But patients can do very well and live for years with platinum-sensitive recurrent ovarian cancer. And there's an ongoing huge question being addressed by GOG 213 and the desktop studies in Germany about whether surgery is indicated. And we have three common combinations: carboplatin and pegylated liposomal doxorubicin, carboplatin and gemcitabine, carboplatin and paclitaxel, that are all reasonable options for patients. And patients often will have a recurrence more than 6 months later and go through the same system, a combination platinum-based chemotherapy. But at some time, they recur within 6 months of platinum, and then it's palliative chemotherapy. And essentially, we choose treatment based on toxicity. Monthly chemotherapy that doesn't make you lose your hair is popular. If you don't get neuropathy with gemcitabine, that's popular. Weekly topotecan, weekly paclitaxel, pemetrexate are all reasonable options. In terms of questions at that time, you have to consider, are you going to add bevacizumab to treatment? And we'll talk about that. There is a risk of gastrointestinal perforation, and you will be buying only a progression-free survival advantage in terms of the statistically significant evidence that we have. And can you put people on a clinical trial? And now we really are doing much more rational clinical trials. High-grade serous tumors, we're really interested in the PARP inhibitors, endometrioid tumors, PI3 kinase inhibitors, and other inhibitors of targets on that pathway. Anti-angiogenics for clear cell tumors, a number of other targets, though it doesn't look like KRAS is a good target for mucinous tumors, and low-grade tumors, MEK or BRAF inhibitors. In terms of where we've come a long way. So the really heroic surgery is a long time ago. 200 plus years ago, there was actually, I think the local pastor stood over the door whilst the primary care took over this tumor. And it said that the local pastor had a shotgun to keep people away because this was thought to be a demonic aberration cutting into people who had cancer. But this was years before ether anesthesia and sterile technique, and we mentioned Dr. Meigs. So the chemotherapy has really come a long way, and bevacizumab looked interesting in 2010, but it shows you how long it takes to get things approved. The last drug was 8 years before the approval of bevacizumab in 2014, and the same year olaparib was approved. Surgery is clearly important. I'm a medical oncologist. I can't talk to this other than to say I love working with surgical colleagues who really are the backbone to getting patients cured. Radical surgery with debulking is a really important start to the experience. In terms of patients' experience, there are 4 seasons. So if we look at that y-axis, the CA125, the first season, they present with an elevated CA125. They do great on treatment, and the hope is for cure. And then they have recurrences, and those recurrences speed up, but the hope is for remission. And then at some point, they're just constantly on treatment, and they hope for quantity. They're trying to buy time. And then as the end of life approaches, often heralded by bowel obstruction, their goal is comfort, and their patients are hoping for quality. This is some of the best data in terms of prognosis. So we have survival here. Everybody's on the curve, and as they die, they come off the curve. And so at 5 years, there's a significant number of patients surviving. So generally, more than a third of patients are alive 3 years later. This is all comers in this analysis. The BRCA1 mutation carrying patients, 44%, and BRCA2 slightly better at 52%, so more than half alive at 5 years. And I'm going to use that timeline to sort of remind you about important definitions. So you get 4.5 months of chemotherapy, and then if you recur more than 6 months later, that's platinum-sensitive disease. And the platinum-free interval is really a major definer of how we think about disease. If disease progresses on chemotherapy, and increasingly within 2 or 3 months of finishing platinum, we call that refractory. But resistant is the clearest definition. That's recurrence within 6 months of last dose of platinum. Some people will call that interval between 6 months and a year after completing treatment partially platinum sensitive. But potentially platinum sensitive disease is really any recurrence more than 6 months out from treatment. And a decade or so ago, there was a lot of work, mainly done with topotecan, about adding in a non-platinum drug to try and improve the platinum-free interval. And that failed in formal studies and then was really buried by Rustin's study, and we'll talk about that. So in terms of options for patients, this group is first-line therapy. This is for that partially platinum-sensitive group of patients, and this is a very European sort of concept. We'll talk about this in a second. And then the standard 3 options for platinum-sensitive disease and options for platinum-resistant disease. So a common choice for treatment might be optimally cytoreduced patient who gets intraperitoneal cisplatin and paclitaxel. And they get a recurrence that's platinum-sensitive a year or 2 later, and they go on carboplatin and pegylated liposomal doxorubicin per the Calypso study, and that's really popular here. We've had a number of studies that have then looked at consolidation PARP inhibitors, so you can sort of roll straight onto that. And by the time you have progression of disease after that, you're sort of, I want to get into trial, and our most popular trial has been an antibody-drug conjugate, now called mirvetuximab. By the time disease has progressed on that, you say, I haven't had bevacizumab. And the best way to get bevacizumab is concurrently with weekly paclitaxel, so that's a clear choice. Once you've had 3 prior lines of therapy, the risk of gastrointestinal perforation starts to increase. It's then a long time since you've had platinum, and you might go back to platinum. Single-agent carboplatin might be more popular. Pegylated liposomal doxorubicin, pemetrexed, etoposide. Patients get through multiple lines of therapy. So Griffiths did this great study from Liverpool and showed that if you had progression of disease on 2 lines of therapy, the chance of responding to the next line of therapy was so small. So that's often the trigger that determines when the utility of chemotherapy is failing. The Rustin data is shown here, and a large number of patients were randomized to either know about their CA-125, both the doctor and the patient, and get chemotherapy immediately that CA-125 rose, or to be blinded to that information and at symptomatic progression get treatment. And so this is the overall survival, and early treatment, typically 5 months before, did not impact overall survival. If you got early treatment, you immediately went on treatment, and this measures your quality of life. Same is true, you've got earlier third-line treatment. This measures your quality of life, and the patients who didn't get chemotherapy and had a recurrence 5 months later didn't have this horrible fall in quality of life and always had a better quality of life. So the only thing early treatment with palliative chemotherapy achieves is a decrement in quality of life. So the timing of palliative chemotherapy is really important. Olaparib. Angelina Jolie has really been the best advocate for this situation. You can see the change over time, and now a significant number of patients, this is all comers, get preventive mastectomies. She did this because her mother died of a BRCA1 mutation-caused ovarian cancer, 56-year-old. We lost a great actor, and she lost a mother. And that really did set the BRCA story into national headlines. So this is BRCA1, and this is the binding site. BRCA2 is much bigger, and this is more associated with other tumors, pancreatic, prostate cancer. This really is only breast and ovarian cancer. The story about other interactions is really expanding, though. So BRCA1 and 2 are the most important part of the story. There are other genes that contribute to failed DNA repair. The ones that are now getting more interest is in gastric cancer, particularly ATM, PALB2 in ovarian and triple-negative breast cancer, and CHEK2. And all of these are potentially targets. They impact homologous recombination. And this understanding of the Fanconi anemia pathway is really potentially expanding targets for PARP inhibitor action. These are the PARP inhibitors that are being investigated at the moment. The first one that we got our hands on was BSI's drug, iniparib. This is iniparib. And this target is really what is seen as a key group in all of these PARP inhibitors. So we liked the simplicity of this drug, but this is not a PARP inhibitor, and it was a sobering introduction to the whole field. Olaparib is now FDA approved, but other drugs, niraparib, rucaparib, talazoparib, veliparib, are all undergoing active investigation. This is olaparib sitting in the poly-ADP ribose polymerase clef. This is the enzyme, and it's inhibiting it. And it is a potent inhibitor of poly-ADP ribose polymerase. It has good pharmacokinetics, so it's relatively bioavailable. And actually, if you give doses, there's a decent concentration of the drug in 24 hours. Most people who've been involved in investigations will say, well, it's a horrible capsule. So the actual drug has great bioavailability, but getting it into a tablet form is really difficult, so that's now arriving. So the first clinical experience was a phase 1 clinical trial. If you look at this tumor here, substantial shrinkage of a tumor, and then this one here disappeared completely. This is a sort of waterfall plot demonstrating how long the treatment duration is. This is normally now demonstrated as a swim lane plot, but you can see patients were on treatment for really quite a long time, and these included patients with ovarian cancer who really did remarkably well in this phase 1 clinical trial. We were involved in the first phase 2 clinical trial, the iceberg study, 2 cohorts. This cohort did not do well, but this cohort, 400 milligrams twice a day of the capsule, really did very well. And 33% of patients got a confirmed response. You can see that more patients got a shrinkage to more than 25% on this line, more than 30% on this line, sorry. But these were unconfirmed. So this was the confirmed response rate in that study. And there are a lot of studies going on now. So I'm going to breeze through these slides, but they're all referenced, and this is a nice summary of things. So the one I just showed you was this one here, with a 34% response rate in the final manuscript. And then there's been a number of other phase 2 clinical trials of olaparib. A huge number of patients went on rucaparib's phase 2 clinical trial, Ariel 3, and then the niraparib jumped from phase 1 to phase 3 clinical trial. Veliparib in phase 2, not too big a study, but a similar response rate. This is probably not much smaller than this. And people have said that talazoparib, which has higher PAR trapping, has a higher response rate, but this is a tiny phase 1 clinical trial, and this is amazingly really not out in any form other than in trying to get you to invest forms. The phase 2 efficacy trials were then randomized. Could you get an early hit? So essentially, hoped that this study would be a winner. Patients would get a pegylated liposomal doxorubicin, or 2 of the doses, not that 100 milligram dose that was obviously too low. This was a small randomized trial, and essentially it was negative. Similar response rate and similar progression-free survival. So this was really sort of sobered things up, and actually the drug got put on hold after this study. Study 19 and Study 41 were without and with concurrent Taxol carboplatin, but this is the big study that's driven a lot of things, and there's been 3 analyses of overall survival, and you'd think that this translates into a 27% reduction in the risk of dying if you're in the PARP inhibitor trial. This is a really impressive p-value, but what's called spend alpha with these multiple analyses, so it's actually not significant. So we still don't have an overall survival demonstrated for olaparib. The hope is that in phase 3 clinical trials we are going to see that, and the first one to report for olaparib is Solo 2, that'll be at ASCO next year, and then Nova is at ESMO. So these are the data that's come out already, incredibly encouraging, but yet to be presented at ESMO. In terms of toxicity, they are quite different. So for olaparib, it really is fatigue and nausea, and everybody worries about developing myelodysplasia and AML. This is quoted at 0.7% of patients, and it's probably the same for rucaparib and niraparib, same sort of level. What's notable about niraparib is there's a substantially greater amount of thrombocytopenia. And there's some other curiosities. Liver function abnormalities really only seem to happen with rucaparib. So bevacizumab, in terms of bevacizumab, the best data come out of the Aurelia study, and this was the data that was taken to the FDA. And actually, the backstory is that the FDA asked to have this data presented to them. So patients for platinum-resistant disease either got chemotherapy or chemotherapy concurrent with bevacizumab, and they were allowed investigator's choice chemotherapy, paclitaxel, topotecan, pegylated liposomal doxorubicin, and the goal was really to look at progression-free survival. It was not powered to look at overall survival, but there was a planned analysis of survival once there were 70% of patients had died on study. And this is the progression-free survival, and you can see that on average, there was a doubling of the time to progression of disease. And in the data they took to the FDA and 361 patients, this hazard ratio was really impressive. So if you got bevacizumab, you were 62% less likely to have had progression of disease at any time it was evaluated. And overall survival was very similar, 16 months, 13 months in patients who just got paclitaxel or whatever their uncontrolled arm was. But if you looked at the group who got paclitaxel and bevacizumab, the progression-free survival for paclitaxel was improved by nearly 6 months, and overall survival was improved by more than 9 months. So you lived more than 9 months longer. This was an impressive hazard ratio, but it was not statistically significant. We worry about gastrointestinal perforations, but this was 1.7% of patients in the group who got paclitaxel and bevacizumab, so not a high risk of GI perforation. To really drive home that message, this is the overall survival. This really isn't better. If you look at the patients who got pegylated liposomal doxorubicin, you can see adding bevacizumab really does nothing to survival. But if you add it to paclitaxel, there's some real magic. This is overall survival, and clearly, if you're a patient, you want to be on this when you're a participant in a clinical research study. Immunotherapy. So immunotherapy is unproven, and if you ask half of the oncologists, they are sort of skeptical and disillusioned, and it's disappointing. If you ask half of them, they absolutely buy into the sort of front page TV advert excitement that we've come of age and now see this as replacing chemotherapy for cancer. Why poison ovarian cancer patients with chemotherapy? Last year, 2016, ASCO said this was the advance of the year, cancer immunotherapy. Really very exciting. There are 3 trials that have been presented. This is the only one that is in a peer-reviewed publication. And just to show you those pictures, this is a big mass on the side. This is a serous tumor, and it's substantially shrunk down here. This is bulky clear cell cancer, and this disease disappeared. This is a loop of bowel, on the edge of a loop of bowel. To have a complete response in clear cell carcinoma, there was actually a third response, another partial response in a second clear cell cancer. Great CA125 responses in these patients, some in other patients, but very exciting. And then the data from this was the pembrolizumab study. And similar sorts of things. So you could say, oh, that's disappointing. 3 out of 20 in the previous study, 3 out of 26 in this study, 15, 11, 12%, a little bit disappointing. The third study, avelumab, an overall response rate of 11%. So there's not a high response rate. But of the 2 clear cell cancer patients who went on, both got a partial response. So this is the timeline. I do want to go through this really fast just to put into context. So if you look at the sort of big picture, 1788, Jenner did the first vaccinations in Paris. Coley did toxins in the US 100 years later. It's 100 years after that we're understanding the biology. Dendritic cells are discovered. Those are the cells that process antigen and drive T-cell behavior. Interleukin-2 was approved for renal cell cancer and melanoma in 1992. And so since then, things have really changed. So ipilimumab was shown to have activity in melanoma in 2008, improved survival, as approved in 2011. Nivolumab activity in melanoma, renal cell, non-small cell lung cancer. Pembrolizumab approved in 2014. Nivolumab the same year for a survival advantage in melanoma patients. Nivolumab approved for melanoma that year, and then approved for lung cancer the next year. But soberingly, nivolumab, they just released this. This hasn't been peer-reviewed yet. It looks as good as chemotherapy, but it is not better than chemotherapy as first-line treatment. So there is a hot debate about what is the right thing. And one of the frustrating things is we don't really have predictors for who would do better with chemotherapy. Atezolizumab was accelerated approval for bladder cancer. That's the latest one to be approved. So just to summarize the biology, tumor releases antigen, and that is presented to those dendritic cells. Those dendritic cells prime the T cells who go to the tumor, and it's the infiltrating T cells that are really doing the work. They recognize and destroy the cancer. So anti-PD, programmed cell death, and anti-PDL, programmed cell death ligand drugs block the normal blinding of that driver. So that's sort of where we're at with those. They have totally different side effects. Diarrhea is the biggest one. So if you get grade 3 diarrhea, you get steroids scoped, and there's now very rarely that people have fatal toxicity from this, but it's a different toxicity profile. And we normally quote for nivolumab and pembrolizumab under 5% incidence of getting admitted for that. So we now have 20 minutes to go over some of these cases. So patient 1. So this is a 68-year-old first grade teacher, and she presented, they did a CT chest scan for what was definitely pulmonary emboli, and then they thought, something else is going on here. And so actually her abdominal scan is a non-contrast scan and shows this big mass. So question, is anybody brave enough to say, how would you treat this lady? She has ovarian cancer. The radiologist rings you up and says, man, she had a pulmonary embolus because she has ovarian cancer. So this lady actually got a very gutsy surgeon. I was a bit rude about A.K. Goodman earlier on with a review article, but Dr. Goodman took this lady to the operating room. Pretty fast after PEs, she got a complete cytoreductive surgery, and actually turned out that all this change up here that was initially interpreted as a mental disease was just inflammatory reaction to endometriosis that the patient has had, and this was the tumor, and it was a stage 2C clear cell carcinoma in the ovary. Now, even more gutsy was what you do next. So how would patients treat how would people treat this patient? Dose-dense paclitaxel, carboplatin? Would you give bevacizumab? Would you give intraperitoneal chemotherapy? So one of the commonest things to do in this group is to think about adding bevacizumab to paclitaxel and carboplatin. If you add bevacizumab, you may have a really good anti-angiogenic effect to microscopic tumor that's still likely to kill this lady in the future, and keep that dormant. And if you don't cure her, buy time would be the suggestion from ICON 7's European data. In the group of suboptimally cytoreduced patients, they actually did, they had an overall survival advantage. Now, that wasn't recapitulated in GOG 218, but it's a reasonable thing to do. A cost-effective thing to do is to give carboplatin with weekly paclitaxel. So dose-dense paclitaxel does just as well in terms of improving progression-free survival. So I have to say, Kathleen Hill is a shout-out for you, Kathleen. Paclitaxel carboplatin is the right treatment for this lady. Somebody that Lilia added the debulking and paclitaxel. So good job, and thank you for contributing Q&As. It definitely will enrich this section. So patient 2. This is a 65-year-old lady. She was an academic athlete. She was a trainer, worked in a Massachusetts college, incredibly fit lady, and she presented with this CT scan. So this is one cut through the pelvis. This is her uterus, and this is the cancer here. And you can see that it's really hard to sometimes differentiate a right-sided ovarian cancer. This is oral contrast in loops of bowel. This is IV contrast, but it's not a very well-caught CT scan. This is our CT scan. You don't see a big difference between the artery and the vein, and so you really can't see this ovary very well. This is a little bit sort of non-specifically red, probable left ovarian mass, but over here, unequivocal metastatic disease in her omentum. So any suggestions on how you would treat this lady? Maybe Lilia, she says debulk and chemotherapy, so you get a shout out for this. This lady got a complete cytoreduction of a grade 3 serous, grade 3, stage 3C fallopian tube cancer. So this is actually a fallopian tube cancer here. And she did have bilateral serous tubal intraepithelial carcinomas, those sticks. So this was about to become a cancer on the right-hand side. And so how would you treat this lady? Sorry about the formatting. Any suggestions? So we elected to treat this lady with intraperitoneal chemotherapy, and so she got the sort of full 100 milligram per meter squared cisplatin, the 24 hours of paclitaxel before that, and day 8 IP Taxol. Laura, do you want to make a comment about how we get patients through intraperitoneal chemotherapy?
Regardless if it's inpatient or outpatient for day 1, 2, and day 8, most of our patients do very well, obviously following the NCC guidelines for antiemetics. And then we do a lot of additional IV therapy either at home or coming into the clinic. And I certainly have very close phone and email contact with my patients, so if they do suffer any additional side effects, we are keeping our fingers on the pulse with them at all times.
My pitch to our patients is that Laura Sullivan is a national expert on bowels, but the patient has to be a world expert on their own bowels. And in terms of the patient experience, I would say fatigue and constipation are the hardest things. We do have about a 25% complication rate, and getting patients through is a labor of love. But if you select patients, they can get through the full dose cisplatin IP chemotherapy treatment. So a third patient, we haven't really talked much about this patient, but this is a challenge. Look at that CT scan and see if you can spot the abnormality. If I'll shout out the name of anybody who says you can type in roughly where the abnormality is. So this is gut, this is colon, and this is small bowel, this is spleen, stomach, this is the liver, the heart's up here. These are kidney stones. This is a kidney, muscle. This is normal, change in the muscle. Small bowel and the pelvis. This is the bladder. Oh, nobody's volunteered a name. This is the tumor here. And this is a granulosa cell tumor. And this patient is actually a nurse and lawyer, and she presented in 2000 with hemoperitoneum. So this is a very different looking tumor, doesn't typically go to the lymph nodes. It's peritoneal metastases, really prone to rupture and bleed. So adult granulocytic tumor, it's very different. In that time, we typically gave BEP chemotherapy. This is a complete misunderstanding that these were stromal tumors, and they are, but they are not germ cell tumors. So she got 3 cycles of BEP and terrible neuropathy, and said, I'm never doing chemotherapy again. She had recurrence, 4 years later, had surgery and actually had some cognitive impairment. She does fine, she functions, but she really got affected by surgery. And she said, I'm not going to do chemotherapy. And amazingly, 6 years later, she had surgery, nearly died, and actually had a repeat surgery a year later at MGH. This is when we met her. And so she then got hormonal therapy for granulosa cell tumor, weekly paclitaxel, because that looks to be better than platinum, probably, for granulosa cell tumors. We did then give her carboplatin, and she again had progression of disease. So any suggestions on what would be your next line of therapy for a patient with multiply recurrent granulosa cell tumor? So this lady is a fabulous patient, and she was due to go off to the Caribbean, and we said, well, do you want to start? And she said, yep, I'm prepared to start. And we gave her bevacizumab. And so tragically, she had caught Zika in the Caribbean. You may or may not know, it's often conjunctivitis plus flu-like illness. She caught Zika and then had abdominal pain, sort of toughed it out, feeling like it was all due to the Zika virus, came back and had a fluid collection in her abdomen. So we felt like she had got microperforation. So Renee Dahlberg said paclitaxel and bevacizumab. That is awesome. I would absolutely say that. We voted the same way. We gave her bevacizumab, but she's unfortunately had a GI perforation. She's doing fine. She's got years to go, but she had the feared complication from bevacizumab. So well done, Renee. Patient 4. So this is a 34-year-old lady. She's a physician's assistant, absolutely fabulous lady, has a terrible, terrible disease. Now, you won't be able to tell probably looking at the scan on her pelvis, but she was born with a bladder extrophy. So she has, and again, you won't be able to tell, unless you're a really red-hot radiologist, that this is a bicornuate uterus here. So we don't think that that was the precursor to her tumor. She had, and it's just behind here, you can't see it on the CT scan, a sigmoid pouch and ileostomy, and lived with that for a long time. She had all this sort of surgery in the first year of life. And we don't know whether the sigmoid was the source of her mucinous tumor. We don't know whether it was the mesh in her pelvis that was the source of the mucinous tumor. But these metastatic or primary ovarian masses, and we decided that she had a pelvic tumor, an ovarian cancer, just based on her scan. She had some peritoneal disease, which isn't well illustrated on the scan. She had bone metastases, and she had bilateral bulky masses. Core biopsy confirmed a mucinous tumor. So there's been a lot of interest in what is the right treatment, and we actually gave her sort of what the study then suggested probably wasn't the right treatment. Any suggestions on first-line therapy for mucinous carcinoma of the ovary? We'll give you a moment to type and shout out if something comes up. There you go. Fox, Rizmi. Good job, Rizmi. So that's exactly what we did. We gave Fox and bevacizumab, and she actually did really well for a year. The study that looks at this, it was an international study. 54 patients went on study, and it randomized patients to get bevacizumab or not, and to get Folfox or paclitaxel carboplatin. And actually, the paclitaxel carboplatin patients looked like they were doing slightly better than the Folfox patients. And Folfox is a 2-weekly slog with more neuropathy, or more problematic neuropathy. The bevacizumab really did seem to add something. So adding bevacizumab in first-line therapy is really reasonable to do. Because it was only 54 patients and not statistically significant, but about a 50% improvement in progression-free survival for adding bevacizumab. So our fifth patient, so this is a 53-year-old community college lady. She is now a long time out, you'll see from the dates. And I'll shout out the name of anybody who spots what this is. So this pink inflammatory tissue was in her pelvis, and then these nests of tumor arose. So she presented with a mass in her pelvis, And at surgery, and you can see how long ago this was, she's still doing great, she's still in remission. Her surgery was impossible to do the usual hysterectomy. Her pelvis was so badly damaged by endometriosis, and she had a supracervical hysterectomy, bilateral salping growth oophorectomy for a densely adherent grade 1 endometrioid tumor. It actually wasn't very big. It was her endometriosis that was really difficult in the pelvis. This was a small tumor, but it ruptured at the time of surgery. So the plan was to get chemotherapy, and halfway through chemotherapy, we elected to do another surgery. Any suggestions why we did that surgery halfway through her chemotherapy? So she had bad endometriosis, and this was actually before the mechanism. You remember 2011 was when ARID-A1 was described, but people did know the association between this. She had a high-grade endometrioid tumor, and the question was, would we dovetail in radiation at this time? And we had a really fierce debate. We, in the end, decided that the risk of lymphedema, long-term bowel consequence, because she had such bad endometriosis, that we were not sure that there was an overall survival advantage for radiation, and so she completed her 6 cycles of Taxol and carboplatin. But for endometrioid and clear cell carcinomas, trying to finesse in radiation at the same time is really sort of good. Paulo Carvalho has put in dose-dense platinum and carboplatin. That's an interesting regimen for these sort of tumors. I think being creative when you have a rare situation and tailoring the data to practice clinically appropriate evidence-based medicine is really the right way to go. I think it is true that you can sort of be more creative about things. Taxol for recurrent endometrial cancer is probably better than anything else. And how much paclitaxel contributes to the benefits of carboplatin paclitaxel for endometrial tumors up front is not really ever being teased out. So dose-dense paclitaxel might be something to do in these sort of situations, but a lot of this is hand-waving and uncertain. We're getting into our last 5 minutes, and we have a final case. So the challenge is, get ready for this in terms of trying to throw out a suggestion, is what do you do next? So our last patient, patient 6, this is the tumor from her most recent CT scan. So this is a coronal view. This is her liver, her large bowel, small bowel, and you can see persisting mental nodules. So when she was in Ukraine when she was first presenting, and at diagnosis they confirmed a BRCA mutation. She has a strong family history. Very creative treatment. She actually started with IV-IP chemotherapy, then came to interval cytoreductive surgery. This is sort of, I put in the details because this is not a standard treatment. And then because of unacceptable toxicity, she completed 4 cycles of paclitaxel carboplatin. They clearly were trying to cure this lady, and that is laudable. But sadly, she had recurrence. 2 years later, we put her on a clinical trial, an NCCN-funded clinical trial with pralatrexate. And then afterwards, she went on Aerial 3. So she got placebo or rucaparib consolidation. She had a progression of disease, and she is, when this scan was done, halfway through carboplatin and the antibody-drug conjugate mirvetuximab. So the question is, I should send chocolates as well as call out a name for this one. What do you do next? So we're at this place, and we are genuinely thinking about what this lady should get next in terms of treatment. Okay, so we elected to, here we go, olaparib. Jennifer Kubo, if you email me with your work address, I promise to send you some chocolates. So you're absolutely right. So if she was on placebo, then she's had 3 prior lines of therapy, and she's eligible for olaparib. And the FDA does not say at progression, it just says you have to have 3 prior lines of therapy. So SOLO 2 is here. The Europeans approved, based on study 19, olaparib after 2 prior lines in this situation of what they now would call switch maintenance. But it's available to her having had 3 lines of prior therapy. So she could do consolidation olaparib. Jennifer says, thanks. Good job, Jennifer. So olaparib is absolutely okay. And then there is a European study of, say she got rucaparib, there's a European study rather nicely called OREO, olaparib for recurrence in epithelial ovarian cancer, OREO. And so treatment across multiple lines, rucaparib, olaparib, and it's powered to find a survival advantage. So olaparib would still be a reasonable thing to do. We're actually electing to give her the full 6 cycles of chemotherapy. She could get bevacizumab per sort of OCEANS. She could get maintenance antibody-drug conjugate. She could get olaparib, as has been suggested. She absolutely could get a break and try to maximize her quality of life with all these things next. The big question to us is whether we can get her on a study which gives her a PARP inhibitor plus an immunologic. So it turns out that your antigenic load illustrated here is a predictor for benefit. So ovarian cancer doesn't have a very high antigenic load. We talked about the aneuploidy, but not so many mutations, so it's relatively lower down on the list. But the BRCA patients probably are higher on the list with more mutations, and that may be a predictor of benefit from immunotherapy. So we're actually actively hunting around for a PARP plus immunotherapy study. We are writing those at the moment, but they're hard to find. There are a couple at the NIH. So, in summary, so we went through ovarian cancer. We talked about the 2 most recent drugs, an 8-year hiatus since gemcitabine for olaparib and bevacizumab to be approved, and the excitement about immunotherapy and what that may do. And all of our practice is to benefit patients. So clinical trials are important, but the clinical care is paramount for people with ovarian cancer. Christine Newby has asked a good question. How are recurrent bowel obstructions best treated?
Depends upon, Christine, this is Laura speaking, that at some point in time patients will call us and come to me with phone questions about problems with their bowels. And depending upon if they've had recent CT scans showing where disease pattern is and where they are in their treatment modalities, I usually will talk to them about coming in, and if it's partial bowel obstruction, we do treat them with inpatient NPO status and NG tubes. And then if it resolves, we could advance their diet and continue therapy. And of course, Dr. Penson will agree, if it presents in a long-term fashion, we do bring in the GYN-onc to consider correction surgically.
We typically tell patients that 80% of the time the first bowel obstruction will resolve with conservative management, but we also tell patients that typically also heralds the last 6 months to a year of people's lives, and we have a low threshold for putting in G-tubes. Definitely for recurrent bowel obstruction, G-tube is our favored approach. So it has been our privilege and pleasure to talk with you today. It's a tough disease, but the changes that we've seen in the last few years have really been very exciting. I think that old disappointment about the fact that breast cancer got all the funding and all of the advances has really changed. And so we can partner with patients with hopes for better outcomes.
Thank you very much for hearing us today, and we hope you learned something from this webinar.
Thank you.